Chair DeGette, and for bringing this hearing together, and thank you all for being here. And I do echo the remarks that you just made. Last week, we held a hearing on the rising costs of insulin and heard from patients, doctors, and patient groups about the rising costs of how the rising cost of insulin has affected Americans with diabetes. More than 30 million individuals, and I have two nieces, 9.4% of the population in the United States have diabetes. In 2016, about 6.7 million Americans age 18 and older used insulin. The insulin prescribed today is different than the insulin discovered over 100 years ago, and the life expectancy of diabetics has improved dramatically. These innovations should not be underestimated, and a lot of exciting research is on the horizon. Someday soon, I hope we will have a cure for diabetes. As we discussed last week, however, the average list price of insulin nearly tripled between 2002 and 2013, making this vital drug unaffordable for too many Americans. Many argue that while list prices have been increasing, net prices have stayed relatively the same or have even gone down. This sounds great because in theory, no one is supposed to pay the list price for insulin. However, if a patient is uninsured or underinsured, they may end up paying the list price or close to it. We've also heard that more Americans are paying the list price at the pharmacy counter for part of the year because of enrollment in high deductible health plans has increased. We have struggled to fully understand, and I emphasize this, fully understand why list prices for medicines such as insulin have continued to rise. The prescription drug supply chain is complex and lacks transparency. We have had a lot of conversations with participants in the drug supply chain over the last 2 years to better understand how the pricing and rebating system works. We've been told that manufacturers set the list price, and therefore lowering the cost of prescription drugs is as simple as manufacturers lowering their list prices. On the other hand, we've heard that manufacturers can't simply lower their list price because the pharmacy benefit managers, or PBMs, demand larger rebates, and if the manufacturers do not provide them with these rebates, the PBMs won't put their drugs on their formularies for health insurance plans. Although they're not on the panel today, we've also heard concerns about other entities in supply chain, such as health insurance companies. And as Chair DeGette said, I'll emphasize, we're not here to point fingers at that. That's what we've heard. We want to try to get to a solution. While some may think that one party in the supply chain is solely responsible for the rising price of drugs, there are incentives to increase list prices throughout the drug supply chain. Beyond the potential for manufacturers to make more money by raising prices, a higher list price allows manufacturers to provide larger rebates to PBMs, most of whom have contracts that allow them to keep a percentage of the list price or receive fees based on the list price. Additionally, the health insurance companies decide whether to pass the rebate along to the patient at the point of sale or keep the rebate to lower premiums across the board for all beneficiaries. The current system contains many incentives for list prices to increase rather than decrease. Unfortunately, while we keep hearing assurances that net prices are staying flat or decreasing, and that almost all rebates are passed on to the health plans, we know that many patients are being disadvantaged by this system and are paying more for their insulin at the pharmacy counter. Your companies have taken steps to try to reduce out-of-pocket expenses for insulin to the patients who need them, and that is a good thing. I worry, however, that these are only short-term solutions. It is important that we collectively find a permanent solution that improves access to and affordability of medicine such as insulin. I thank our witnesses for being here today, and I will yield the remainder of my time to my friend from Indiana, Ms. Brooks. Thank you very much. Thanks for being here, and I'm going to use a quick example just because to try to make it simple. I've been wrestling with this for about a month and trying to figure out what's happening. So if I wanted to, if Chair DeGette was making this phone and I want to buy, and she said she's willing to take $100 for it, but she says, I'll sell it to you for $300, give me $200 back. I mean, that doesn't make sense. Or Chair DeGette's willing to take $100, and I say to her, hey, I'm willing to pay $100, but charge me $300, I'll give you $200 back. And the whole idea is that Brittany is the purchaser at the end, and I'm giving that to her for $100 because she's the plan, she's saving the money and passing it on to her consumers. And what we're trying to figure out is where that delta is going. It's just hard to figure out. And so, and I've been spending a lot of time on it. So on February 6th, so the three manufacturers, I want to try to, because I got a few questions to try to go fast. You said that your net price, your list price has gone up, but your net price has gone down. What would happen if you just said, hey, I want to make my list price my net price and put it out on the marketplace? So I'll do you three.
First of all, we are dropping our list price of Humalog by 50% with our launch of Lispro insulin. For us, there is many people who have access, the vast majority of people have access for insulin at affordable costs through their health plans. That's not tied to list price. So we don't want to disrupt those by lowering list price. And so we think the best way is to provide, in the short term, is to keep our list price at the way it is, so we don't disrupt those individuals, we don't harm the access that they have.
But if you're willing to take, I think you said you had I don't know, whatever the net price is. I know net prices are different with different plans. There's not one net price. I get it. But if you're willing to take a net price for your product, and three of you here, why wouldn't that be something out there for everyone to pay? I mean, that's what you're willing to charge, right?
It's just more difficult to do that, to disrupt that for a product that's on the market place today, because people have affordable access.
But you've had your net price, according to your testimony, go up 207%, where your list price dropped by 3%, according to the letter on February 6th on Humalog. And I think you all are similar too. I don't want to just do Lily, all of you guys as well. I mean, that's kind of, so we see the net price going up. I understand what you're saying, but we see the net price rise, and we don't know why is it doing it. Maybe there's a market reason for that, and it's benefiting consumers, but we want to know.
So in the current system today, the most important thing for us is for the most number of patients to get our brands at the most affordable prices. And in the system today, that is the current formulary positions. Just the 3 PBMs here today represent over 220 million covered lives.
Okay, you said there were perverse, okay, I'm
So
going to have time.
that's 80% of the lives. So for us to lose one of those positions, that would be a dramatic impact to patients in terms of the medicine that they're on, physicians in terms of their choice.
In your argument,
and
is
there would be a
you would
business
lose
impact.
your position on the formulary if you lowered your price?
In the current system, if we eliminated all the rebates, yes.
You're shaking your head the
We believe
same
that we
way?
would be in jeopardy of losing.
You said
those
there were
positions.
perverse incentives. What are the perverse incentives?
Well, we're spending almost $18 billion a year in rebates, discount, and fees. And we have people with insurance, that with diabetes, that don't get the benefit of that. So
What are the perverse incentives for that 18 billion in rebates? You said they're perverse.
they're going into the
That's
system and they're misaligned, right? So that's, we believe that they should go back to the diabetic patient.
The issue here, Congressman, is not one of negotiation. The PBMs are very effective negotiators. It's what happens with the results of that negotiation. Those rebates are not necessarily going all the way through to patients. They're being used for other parts of the system. And we don't have visibility to how those rebates get used. Those rebates are part of how we secure formulary placement and cost sharing for the patients that are covered by those plans.
Would you say, so you say I'm willing to take X for a product, but for me to get on their formulary, I know I'm going to have to raise my list price because they don't want rebates? Is that what you're arguing?
That the rebates is how the system has evolved. The rebates are part of the negotiation to secure formulary placement and associated
I went too long on that side because I'm not giving you, y'all talk to that, I guess. I had other questions, but I'd rather hear your responses to that.
So, as mentioned previously by my colleague to my left, of course, we're looking at the clinical attributes of a product. I know you want to get to the economics. The way we make formulary decisions is based on net price. And if every one of the manufacturers to my right wanted to reduce their list price, there would be no implication to the rebate status so long as the net price remained the same.
So on my example, if she's willing to sell for me 100 and I sell to Brittany for 100, and you're saying rebates keep the price down, but in the end, because you're selling to her at the net price, so why wouldn't the net price be? What we're trying to figure out is it seems like there's a price that's marked through the system that seems to be based on something, but there seems to be an inflation in a higher price that just seems to be caught up in the system. But where it really affects people, before, as we've talked about, when they're going to the point of sale, when they haven't hit their deductible, when they have, I know you've got these plans in place, and those are great, but we need to figure out the economics behind it. So if we need to do something here to help people out, we need to understand that. Wish we had more than 5 minutes. I yield back. I just want to close, and when the chair and I were discussing having the hearing, we thought insulin was a proper one to have. One, I know it's different than 100 years ago today, but we had a lady before, a doctor, physician from Yale, that said that there was held up a insulin said it's the same. You're talking about Ms. Schakowsky, my friend Ms. Schakowsky from Illinois. She also talked about President Trump and saying that this is important to him. And in my experience with him is, in meeting with him, is that drug pricing is important to him. So it's everybody. It's uniting everyone. And I'm going to be quick. I know 5 minutes went fast before I get all my questions. I'm not going to ask the question because that's not what I've been recognized for. But innovation is important. I saw a film yesterday of a father talking about his daughter, I don't know if cured's the right word, but not having any symptoms from sickle cell. I mean, it is just hepatitis C you can take with, and you talk about medical devices. You can do the the artificial pancreas is here. So innovation and having a market-based system and a free enterprise system is absolutely important. But what we're trying to get at with this is, and hopefully you can see our frustration, is that we see pharmaceutical companies say our net price is going down. We see the list price going up. And I have friends here from Bardstown that are in the Buddy Carter situation or of community pharmacists, and have described to me situations that he just described, and they have to pay the list price to sell to somebody who's not when they sell. So it's a cash flow to those kind of businesses. And what we're trying to figure out is, if the net price is the net price, then why isn't that what's paid to if the idea is we're going to get the lowest price for our insurance companies, then why isn't selling something for $135 that's cost $135 better than selling something $300 or $400 and getting $300 or $400 back, other than saying I've saved you that money? It's trying to figure out where the money's going. And so this has been informative. I think one question I want to ask that I'm going to do for the record is, so what do you put on the formulary? Is it better for a high list price with a lower net, or that's better for the insurance company, but it's not as good for if it's just a lower net price or just a lower list price, it's actually lower for the consumer going to the counter at the pharmacy. So this is just hopefully the beginning of a series of hearings, and it's been informative, and we do appreciate your willing to come here and your testimony and trying to inform us, because we do have to make some decisions, and we don't want unintended consequences, because if you get into price controls, you get into rationing and you get into shortages, and that's not where we want to, that's not where I want to go. We want people to have a fair price if they can pay, and if they can't pay, to have the assistance to have that, because it's life-saving. So thank you for your indulgence, and I yield back.
I think the ranking member, and I think